So, kia ora everyone. That's the first time I've said that, because I'm from the UK, as you can probably hear. Sorry, can you hear me okay? So my name is Cullum, and I'm a consultant in old age psychiatry. I've been in counties for about 18 months. The last 6 months I've also been senior lecturer in psychiatry in the University of Auckland, because research is my first love. And dementia research is particularly interesting in South Auckland, because as we've already been talking about, there's multiple diversity, languages, cultures, and so on, which also makes research interesting and challenging. So I just want to talk about the D word, as I call it. Most people's eyes glaze over when they hear dementia, and they kind of think of a room in a care home full of people who can't look after themselves. But actually, most people with dementia have mild dementia. You wouldn't know they had dementia. They're a bit forgetful, a bit of word-finding difficulty. And they're living in the community. They just have the same needs as everyone else. And that's why dementia epidemiology is important. So it's a spectrum disorder. There's very little known about the prevalence of dementia in New Zealand. There's been no research, no prevalence studies. This report is probably what gets quoted everywhere. There's been 3, I think, so far, 2008, 2011, 2016. And I just want to point out that lovely picture on the front of this report. I mean, what are they trying to say? So, you know, there's room for rebranding of dementia, I think. So there's been no prevalent studies of dementia, so that kind of, you know, made my mouth start watering. But I want to just say a little bit about what the report says. So globally, there's what they call this dementia tsunami, because the whole world's population is aging, and the biggest risk factor for dementia is age. In New Zealand, the populations that are going to be most effective aren't European, because the other populations are the ones that are getting older more quickly, whereas the European population's kind of already got there. So this is an issue that we really need to know what the numbers are. Just to say that this report bases all its data, its estimated data, from European and Australian prevalence studies. So, you know, it's all modelled. And it's called the economic impact, so they talk about the economic impact of dementia. And I was quite interested by this, because it says there's a 29% increase in prevalence between 2011 and 2016, which is possible because we've got a rapidly aging population. But then there's a 75% increase in costs, and I kind of thought, well, it hasn't tripled the cost of dementia. So I then looked at it in a bit more detail, and not that much detail, because the first thing I came to was they talked about productivity losses in people with dementia. Now, productivity losses means people who aren't in employment. Well, most people with dementia are over 65, so there's not going to be a productivity loss. So what I've put there is GIGO. I don't know if anyone knows what that is. Garbage in, garbage out. So it's a model, so you've got to know what you're putting in there. But most of all, what this points to is that we need some actual accurate data, real data. We could look at New Zealand big data. We've got the IDI, which is, you know, a really good resource. We could merge it with some of the other data, because we've got NHI that we could merge it on. But we actually know from the UK and elsewhere that only, I think I've got that wrong, 1/2 to 2/3 of people actually present to services with dementia. Most, or 1/3 to 1/2 are just unidentified. They're just in the community. So in order to find those people, we need to do a proper population-based, community-based prevalence study. And it's not just an academic exercise for numbers. We need it for planning healthcare, home care, residential care, to measure carer burden. A lot of families look after their loved ones with dementia and not telling anyone else, and they suffer. They're the ones who are out of work. That's where the productivity losses are. So we need to know how much it's going to cost us. So what do we need to do a prevalence study? I mean, basically we need a diagnosis, and we need to ascertain cases, which in New Zealand it means door knocking. And I won't go into the reasons for that, but that's what it needs. There is no definitive diagnosis for dementia, no blood test, no scan. I mean, MRI scans are pretty good, but they're still not definitive. It's actually a clinical diagnosis, clinical assessment. And even within that, there was a study, I think it was Scandinavia, where they looked at this one cohort of people and diagnosed with DSM-4 and then ICD-10. The prevalence was, I think, half in DSM-4 because it's got more stringent criteria. So what we need is a standardised assessment that we can use with everyone, and just one. It's got to be culture fair and education fair because a lot of the assessments aren't. So what we're looking at using is the 1066 Dementia Protocol, which was actually designed for use in low and middle income countries because in various languages and cultures to make it education fair and culture fair. And in fact, you know, people kind of say, well, that's for low and middle income countries, but actually it's an incredibly good tool. It was designed at the Institute of Psychiatry in the UK, and it's probably gold standard. Well, it is gold standard. It's been translated into lots of languages, Cantonese, Mandarin, Hindi, Urdu, Spanish, Portuguese, but not Te Reo Maori, Samoan or Tongan, which is what we'd like to use in South Auckland. So, we've got a lot to do. We need to translate the tool, and then we've got to test its validity in those communities, particularly Maori, Samoan and Tongan, and there are other communities as well, but we're sticking with those for now. And then once we've got a tool that we know is valid, we then need to start using it, and we've got to work out our sampling methodology. So it's a huge undertaking. It is possible, because I did it in Singapore a few years ago with Chinese and various dialects of Chinese languages, Malay and Indian. Cost them $4 million, so it's not peanuts. So in order to justify trying to get that kind of funding, we need to know that we're going to be able to be successful. And the knowns are that we can translate the study documents. We probably can get them validated, but again, we've got to find cases. We need bilingual, bicultural research assistants, probably with some health background. And then we've got the communities themselves. I mean, particularly in the Chinese community, dementia is very stigmatized. It's, you know, we may not be able to get people at all. So we need to start from the bottom up and not top down. We're going to start engaging communities. We've already started, actually, so working with communities that already work with elders, working with the Asian Special Interest Group, Mental Health Special Interest Group, which is mostly health care professionals, but we want to find out from them how do we engage communities. We want them to own the research, that they see something in it for them, that they're invested in the success of the project, that they see that they might get something out of it. And then we're going to focus more on focus groups and family interviews. What the previous speaker was just talking about, stories. So, you know, we already know lots of stories, but we haven't got them down on paper in a publication. So hopefully by doing this, we'll raise public awareness about dementia, and we will destigmatize the D word. So this is our grand plan. So in Maori, Tongan and Samoan communities, we're doing the community engagement, focus groups, family interviews. We also need to do the translation and validity testing. In the other communities, we need to do the community engagement and the focus groups and family interviews. Once we've got that, we'll do the feasibility study, which we're talking about probably 1 or 2 years' time, which is testing the sampling methodology, which is going to be tricky. And then once we've done that, we can move on to the full study. So communities are ready. We have an understanding of their experience of dementia. We've got culturally appropriate research protocols, equitable assessment tools, hopefully bilingual and bicultural researchers, sampling methods. So all we need is the funding.